Okay. Hello, everyone. My name is Fadi. I'm a neurology resident from Iraq. My presentation today will be about myotonia congenita, which is one of the non-dystrophic myotonias. This presentation will be more on the clinical side because, as one of my attendings once said, medical education is best done at the bedside in a busy ward, not in a comfortable room. So we will try to be as clinical as possible. We will start by a case presentation. Our patient today is a 17-year-old boy that presented with an inability to release his hand from a handshake, along with sudden drops of items from his arms. The neurological examination was done, and it was normal except for eyelid and grip myotonia. He also had an athletic physique, and as he mentioned it, a lot of people tell him that he works out, and his answer always will be, no, I do not. It's just how I am built. We'll start by an introduction. Myotonia congenita is a genetic neuromuscular channelopathy that impacts skeletal muscle fibers. It is caused by a mutation in the CLCN1 gene, which codes for the voltage-gated chloride channel within the sacrolemur membrane in the skeletal muscles. It is classified into two distinct conditions: Thomson disease, which is autosomal dominant. It presents earlier in childhood than the Becker disease that we will talk about shortly, and it also has mild features. Becker disease, on the other hand, is an autosomal recessive. Classically, it presents in a more severe myotonic pictures and can progress to a permanent muscle weakness. So what about epidemiology? Historically, the prevalence of myotonia congenita was described as 1 in 23,000 for the autosomal dominant part, which is Thomson disease, and 1 in 50,000 in autosomal recessive myotonia congenita, which is the Becker disease. But as now, it is recognized that the autosomal dominant form is in fact less common than the autosomal recessive. For example, in a cohort of 300 patients in the UK, only 37% was found to be autosomal dominant Thomson disease. The rest was all the autosomal recessive Becker disease. Geographically, both parts are frequently observed more in northern Scandinavia, with a prevalence of 1 in 10,000. This is 10 times higher than the estimated worldwide rate. So what are the important things to ask about in history? See, myotonia is the cardinal features of myotonia congenita. It is clinically defined as a difficulty in muscle relaxation after maximum voluntary contraction. In our patient, this was after a handshake. It is also associated with a transient muscle weakness, which is typically non-painful. This will come later when we discuss differential diagnosis. Muscle stiffness is also observed, and it can be improved by exercise or repetitive movement. This effect is called as warm-up phenomenon, but it quickly lost when the activity stops. For example, if we ask the patient to make a fist, at first he will not be able to release his hand, but after 5 or 6 attempts, he will be able to do so. Muscle hypertrophy is also a feature that it is more commonly observed in the Becker disease than the Thomson disease, and it is particularly variable and visible in large muscle groups in the lower limbs. Men seem to be more severely affected than women, but symptoms worsen often during pregnancy and menstruation. An important topic to discuss on history is how early childhood children are presented. So these features are mostly subtle, and a high degree of suspicion should be put in mind to diagnose myotonia congenita in neonates and children. For example, feeding difficulties such as dysphagia, reflux, gagging, and choking are commonly observed. Children also may seem clumsy and fall often, and that is observed even after they have learned to walk. Patients might also have to have difficulty opening their eyes during prolonged contractions, such as crying, which can be easily observed in children. Symptoms initially worsen after the first appear, but they plateau and remain stable, so there is no disease progression. Now about the fun part of being a neurologist, the physical examination. We have a lot of interesting signs to be observed in case of myotonia. I have some videos and pictures that I will show you later, but we will try to discuss them in a brief at first. In a grip myotonia is observed when the patient is asked to make a fist and then fully open the hand after maximum voluntary contraction. In this case, he will not be able to fully relax his fingers. He may use another arm to open his hand. Percussion myotonia can be easily elicited by tapping the thinner eminence with a reflex hammer. Eyelid myotonia is seen when the patient attempts to open their eyes after they squeeze them tightly. The patient with myotonia will not be able to fully open his eyes, the sclera will not be visible, and they may use other muscles to help, for example, the frontalis, so wrinkles would be easily observed in this case. Lid-lag myotonia, it is basically a delay between the movement of eyeball and the movement of an upper eyelid when the patient executes rapid vertical eye movements. So we ask the patient first to look upward, and then we ask him to look quickly on the floor. In this case, the eyelid will not follow the eyeball, and the sclera will still be visible. Tongue myotonia is not easily observed, but can be elicited by asking the patient to slightly protrude the tongue and then placing a tongue depressor on it, and then gently hitting it with a tongue depressor with a reflex hammer. So this is tongue myotonia. Notice the handkerchief knot. This can be easily seen in like luxury restaurants, and this is a typical sign of myotonia. Here we have percussion and grip myotonia. We will start by eliciting percussion myotonia first. Note the contraction and adduction of the thumb when the thinner eminence is hit with a reflex hammer. And here we have a grip myotonia along with a normal patient, so you can see the difference.
Okay, fist. Go.
Notice the delay in relaxation of the fingers. And here is bilateral grip myotonia.
Fist. Open quickly.
And typically in a patient with myotonia congenita, this will improve after 5 or 6 attempts. And these are the credits of this video. Here we can observe the eyelid myotonia. First, we ask the patient to squeeze his eyes and then to open them. We did not notice it here, but the patient will have difficulty opening his eyes. And you can see that he cannot fully open them. As you know, and notice the sclera is not visible. And the patient is also using other muscles to help open his eyes. Notice the wrinkles in his forehead. And here is a demonstration of a lid-lag myotonia. First, we ask the patient to look on the ceiling, and then we ask him to quickly look downward to the floor. As you can see, the eyeball is already looking down, but the eyelid is lagging, and the sclera is largely visible. So investigations. The diagnosis is mainly clinical, but there are some important investigations to be done. Biochemical investigations are usually unremarkable, but a mild elevation of creatine kinase up to 3 or 4 times of the standard upper limit would have been reported. In another example of muscle dystrophies, for example, the Becker disease, the creatine kinase and aldolase will be much highly elevated. Electromyography shows a repetitive discharge with oscillating frequency and amplitude, a crescendo-decrescendo sound. It is called a diver bomber. And as you can see here, this is the dive bomber sound. Genetic testing is the gold standard for confirming the diagnosis. It reveals the mutations in the skeletal muscles of a chloride channel, which is encoded on chromosome 7 long arm. So what about the treatment? Generally, mild cases do not require treatment, but some patient education is necessary for lifestyle modification, which is the avoidance of precipitating factors like cold and stress. Mild exercise, particularly gymnastics, is also helpful, but more research is needed to demonstrate this effectively. In severe cases, our main treatment is mexalenetide, which is a class 1B antiarrhythmic drug. So his side effects includes tremor, dizziness, ataxia, and gastrointestinal disturbances. And these gastrointestinal disturbances may make some patients not able to tolerate mexalenetide. In these cases, flecainide is an alternative in some patients. Another off-label drugs are used. These may include tocainamide, clomipramine, and impiramine. An important differential diagnosis to be put in mind is a paramyotonia congenita. This is an autosomal dominant SCN4 gene mutation that leads to a defect in sodium channels in skeletal muscle sacroilium. The muscles here are of normal muscle and bulk. This in contrast to the muscle hypertrophy seen in myotonia congenita. There are also specific triggers, and the myotonia is exacerbated by cold temperatures and an exercise, which is called paradoxical myotonia. This, again, is in contrast with the patient that improve after multiple attempts for myotonia congenita. Here, the patient worsen. If we ask him to squeeze his eyes and open it, after multiple attempts, a patient may be not able to open his eyes at all. Pain is also a common experience, which is not seen in myotonia congenita. The myotonia is also more usually in the face and eyes than in the hands or in the legs. Other important differential diagnosis is myotonic dystrophy, type 1 and 2. This is an autosomal dominant CTG trinucleotide repeat in the DM1 and the DM2 gene. Some systemic features are visible almost always in myotonic dystrophy, which helps differentiate from myotonia congenita. These may include endocrine dysfunction, like testicular atrophy and ovarian insufficiency leading to an infertility, cardiac conduction defects leading to arrhythmias, cataract formation, and frontal balding, which classically occurs early in men. Myalgia is often frequently observed, and most importantly, there are different patterns of muscular weakness. For example, myotonic dystrophies are not usually associated with eyelid myotonia. So in a patient with eyelid myotonia, this essentially excludes myotonic dystrophy as a possible cause. About the prognosis, the disease is incurable, though it does not have any systemic effects, so it does not reduce the life expectancy. And once the symptoms of myotonia congenita have appeared, this group of diseases does not typically progress. An important take-home notes is that mexenatide requires monitoring of the QT interval on ECG before and during its use because it leads to QT prolongation, and this may lead to tarsitis de pointis. So an ECG at regular intervals is very important. Another important thing is to make the patient aware that whenever he is making a surgery or any other surgical intervention, to tell his physician that he have myotonia congenita. Typically, we gave him a card in which myotonia congenita is written in bold. This is because, especially with depolarizing muscle relaxant, myotonia congenita has associated with adverse event in case of anesthesia, such as a profound muscle spasm and difficulties in secondary ventilation. These are my references. I mainly used Continuum, which is like the Bible of a neurologist. And finally, I included this picture because, as Stephen King says, hope is a good thing, maybe the best things, and no good thing ever dies. Even at the end of a darkest tunnel, there will be light, and we should always remember that despite the hardship of life, there will always be hope. Thank you very much. And if you have any questions, I'm ready. Okay.
Thank you.
Thank you.